Okay, once again, you are welcome. We are kickstarting, broadcasting live from the Limi Children's Hospital. The topic for today's discussion is pediatric triaging and emergency interventions. With me in the house today, it's a polished consultant pediatrician, fellow of the West African College of Physicians in Pediatrics. Dr. Okoji, you are welcome.
Thank you very much.
Thank you, sir. Okay, fine. So just before we start, we'll make some little introductions. Our hospitals. The webinar going on today is part of the Limi Hospital's ongoing continuous medical education, sponsored by the Limi Hospitals. The Limi Hospitals, we have 3 branches. The Cardiocare Multi-Specialty Hospital, which is a cardiovascular multi-specialty hospital. Apart from the array of seasoned consultants we have in cardiology, endocrinology, metabolism, nephrology, neurology, we do some interesting procedures, cardiac interventions. The cath lab is functional with a lot of procedures going on, a very busy cath lab. We also have the dialysis machines for dialysis, and then consultations for cardiology, nephrology, neurology, endocrinology. We have the Limi Multi-Specialty Hospital, which is a multi-specialty hospital located in Central Business District in Abuja. Departments include family medicine, gynecology and obstetrics with IVF facilities. We run in pediatric services there, rheumatology, general surgery, orthopedic surgery. Our passion and service delivery is centered around the following, which you would know. This is Limi Children's Hospital. Our services include pediatric cardiology. We do echocardiography for children. In fact, cardiology services for preterms, other neonates, children, adolescents, and including adult congenital heart diseases, including those who have had surgeries, monitoring them. We also have our pediatric nephrology, pediatric endocrinology. Right in front of us is the pediatric, the picture here is a neonatal intensive care unit with our giraffe incubators and our dedicated nurses. We also have a transport incubator that could be used for transfer of babies when the need arises for referral of those babies. Recently, we commenced a developmental pediatrics clinic where we take care of children with special needs, including autism, attention deficit hyperactivity disorder, cerebral palsy, and the likes. So this is just a background to understand our services. Similarly, this is just to display our pediatric echo session going on a preterm baby inside the transport incubator. These are services that we do regularly. Dr. Okoji, we would like to know, because the presentation is starting immediately, what do we expect that our audience will get at the end of this presentation?
Okay, thank you very much, Dr. Peter. At the end of this discussion, we should be able to know what triaging and emergency are. And then we should also be able to identify a patient that needs an emergency attention as different from one that needs an urgent attention.
Wow. Okay.
Yeah. And then thirdly, we are going to be able to identify and manage appropriately common pediatric emergencies that we see almost on daily basis. So these are the learning objectives. Yes.
Okay, let's shoot the first shot. Pediatric triaging.
Okay, thank you very much. Pediatric triaging is actually rapidly screening. The word rapidly is very important because time is of essence. Yes, rapidly screening sick children, soon after their arrival in hospital, in order to identify, firstly, is there any emergency sign? This is very important because any child with an emergency sign, like we know, should require an emergency treatment.
Yeah.
And then immediately, as a matter of emergency.
Yeah.
Now, If there are no emergency signs, we look out for priority signs. Priority signs require urgency. You don't keep them in the normal queue for them to wait for a long period of time to see doctors. And then what about mothers that bring their children? A child that is just having fever, just a low-grade fever and maybe catarrh.
Yeah.
What will happen to those ones? Okay.
Well, my child is important.
Every
my child is special.
Yes.
But looking at this standard concept, where do we classify those ones?
Okay, they are classified as non-urgent cases. Non-urgent cases. That does not mean they are not really urgent, but at least they can wait for some time for us to attend to the emergency and the priority cases. Okay.
So it behoves the doctor seeing a child to automatically classify. Where do I classify this child? Is it emergency? Is it priority? Is it important but non-urgent?
Exactly. Okay.
Okay, fine.
Okay, we have a teaser here.
All right.
There are two cases looking at us on the screen. And the first one is a 2-year-old boy in severe respiratory distress with cold, clammy extremities and fast and steady pulse. The temperature is 37.8 degrees centigrade.
Wow, this child is very sick.
Okay. And there's a second one, a 7-week-old severely malnourished girl, severely pale, with a temperature of 39.5 degrees centigrade. Two of them entered at the same time. Who will you attend to first?
All right. So we'll get to see that. Now, this is a teaser for us. While you pay attention, we'll also be glad to hear your comments in the chat box as we proceed. But for me, as a pediatrician, this is a difficult situation to handle.
Exactly.
But I hope that the presentation will do justice to these questions.
Very well.
All right. Thank you. So we'll go to...
Okay. What's the approach to triaging, one may ask? Okay, like we said before, you look out for the emergency signs. Now, the question is, what are these emergency signs? You know, every mother believes that whatever will bring her child to the hospital is an emergency.
Of course.
But as a clinician, one should be able to look at this child and then tease out the emergency signs. Okay, and they are looking at us on the screen. You can use this C3S3O2. Sounds like a chemical
formula.
A chemical formula. So what are they? Number one, is there obstructed breathing? Is there anything that is preventing this child from taking in air the way the child should? Then is this child in severe respiratory distress? The word severe is important here.
Yeah.
Okay, as typified by grunting, that's noisy, very serious noisy breathing. Cyanosis, blueness of the extremities and the lips, as typified by head bobbing. As the child is breathing, the child is nodding the head. That's
answering yes,
yes
to nobody.
Exactly, to nobody. Okay, so these are some of the signs of severe respiratory distress. Another one is central cyanosis. Central cyanosis simply means some dark discoloration on the lips, most at times. Okay, and then signs of shock. Shock here is when a child presents with cold, clammy extremities, and then fast and steady pulse. You can barely palpate the pulse of the child. Okay, and then coma, unresponsive child, then convulsions, and then signs of severe dehydration. So these are the emergency signs. Okay, and then when you have teased out these emergency signs, okay, you manage appropriately. We'll come to that. And then when they are not present, what else do we look out for?
Okay. So let's now see. I was expecting we'll have comments. Okay, someone has already said case 1. Fine.
Okay.
Can we see from the cases, looking at these emergency signs? Let's see. For me, they are both seriously ill children, and you pray not to see those ones often at the same time. But let's see. So let's go back. So case 1, a 2-year-old boy with severe respiratory distress. So severe respiratory distress falls under the emergency signs already.
Exactly.
Cold, clammy extremities with fast, steady pulse already tells us signs of shock going on already. although the temperature here is less than the temperature in case 2, it therefore means case 1 will be taken first.
Exactly.
Okay, we are better enlightened. It's
Okay.
all right, fine. Oops, our slide is quite small here.
Sorry about that. Okay, the second thing you look out for are priority signs. And then the priority signs are number 1, tiny baby, because somebody may ask from our teaser that this baby is actually less than 2 months.
Yes, it's 7 weeks.
Exactly.
Yeah.
But it's actually a priority sign
Yeah.
if the child is less than 2 months. Okay. Then the other ones are temperature. Okay. Even if the temperature is very high, it's still a priority sign. Okay. Then you look at trauma. Is it a case of trauma? Possibly domestic accidents, road traffic accidents. Okay. Then another one is pallor, severe pallor. Severe pallor is also a priority sign. Then you have poisoning. You know, a child can inadvertently, take a bottle containing kerosene, drink it, and then it becomes a problem.
Yeah.
So it's actually a priority sign. Then you also have pain.
Yeah.
Okay. No matter the severity of the pain.
So like a child with sickle cell having acute painful crisis.
Exactly.
Is priority.
With no other thing suggesting emergency is actually a priority sign.
Yeah.
Okay. Then you also have respiratory distress. This time around, moderate respiratory distress, because we have already said that severe respiratory distress is an emergency sign.
Yeah.
Okay. We also look at a child who is restless. It's possible the child is dehydrated and very restless. Okay, is also an emergency sign. And then a child who is referred, has visited 1 or 2 hospitals, and then the child is referred from a hospital, you have to attend to that child urgently. Yeah. Okay, and also malnutrition, severe wasting is also a sign of urgency. And then edema of both limbs is also a sign of urgency. And then major burns. Okay. Then apart from all these listed, the other things that the patient could present with are actually classified as non-urgent.
Okay. Exactly. But we have a lot of parents who are so worried. So we need a lot of skills to manage them while we have to attend to the emergency, the urgent cases. Then we'll now come to those ones, which we sometimes call cold cases. Okay, what are the steps in treatment of emergency signs? So this child is in shock or severe respiratory distress or Glasgow Coma score of 12. Okay, fine.
Now let's start with a child who has obstructed breathing.
Okay.
A child comes and then has this noisy breathing that we call stridor. That shows that this child actually has an obstruction going on. What do? Maybe the child has ingested a foreign body. You first of all manage the airway. You have to remove that obstruction for the child to be able to breathe appropriately. Yeah. And then that brings us to what we call Heimlich maneuver. We're going to talk more about that and demonstrate it further. And when in our further slides.
Yeah.
Okay. Now, but after managing the airway of this child, you have to give this child oxygen. And you make sure that the child is warm. It's very important. Okay.
Yeah. Okay, fine. So essentially, we've talked about the approach. We've talked about basically airway. Okay, so we are looking at circulation.
So circulation can be in the form of an actively bleeding child. It can be in the form of shock. Shock, of course, is one of the commonest presentations of a circulatory failure in children. So when they come, if the child is bleeding, you actually arrest the bleeding, okay, give oxygen and make sure the child is warm. Then your further action, especially if the child is in shock, will depend on whether the child is severely malnourished or the child is not severely malnourished. So you must ask yourself that question. Is this child severely malnourished? Because the approach will differ. For a child who is not severely malnourished, you can get an IV access and correct with fluids. But for a child who is severely malnourished, except if the child is in shock, that's the only time you can correct for shock immediately and then pass your NG tube and do the remaining corrections orally. Okay,
Yeah,
we will give a more detailed distance as we
so
progress.
because in malnourished children, you do not want to overload the circulatory system.
Exactly.
Worsen an already weak heart. Okay, fine. So what if the child is in coma or the child is convulsing?
For a convulsing child, the airway, managing the airway is very important because there could be secretions. So you should suction the secretion so that the child can breathe.
Okay, sorry. What if we see parents that put spoon? A silver spoon or golden spoon. So a child will be born with silver spoon. But what about that?
No, it's highly discouraged.
Oh,
yeah, because they may cause injury in the mouth. I think there was once I've seen a child that the teeth was almost falling off because of the pressure. They were trying to insert the spoon into the child's mouth to prevent the teeth from occluding. Okay.
The tooth could even fall off and
be swallowed.
Get swallowed or get in and obstruct the airway
further
and cause other emergency signs.
Right, sir.
It's all right, fine.
So you also want to give them anticonvulsants. Okay. Position the child appropriately to prevent choking. The child may choke on the child's secretion. So you want to place the child on a left lateral position so that whatever fluid will be flowing out very well. Then you check the random blood glucose of the child. It's possible it's it's hypoglycemia that is causing the convulsion.
Yes.
So if it's low, you correct appropriately.
Yes.
All right.
Fine. So now, if the child is severely dehydrated, we see acute diarrhea disease quite common among our children.
Okay.
Right now, there is even an outbreak of cholera in town. So you have a child that is presenting with severe dehydration. What do we do?
Well, it's in line between the management of severe dehydration and hypovolemic shock. Like we've said before, you also check whether this child is severely malnourished.
Yeah.
That will also guide you. Because like you said, you don't want to overload a flabby heart. Okay, so if this child is severely malnourished, you may want to pass an NG tube and correct the dehydration. But if the child is well nourished, you can use the IV, get an IV access and correct. And then when the child is able to take orally, you switch over to correcting whatever is remaining orally. So
it's okay. So for the child with no severe dehydration, we get the access. We want to use crystalloids to expand the circulating volume as fast as possible. So either we use normal saline or we use urine lactate. But we also want to know the urine output. So if urine output is not sure, we are not sure, we prefer to use normal saline. Okay, fine. Thereafter, so in correction, we have the correction of the deficit, the maintenance, and then the ongoing loss. It's okay. All right, so the presentation is actually on triaging. For those just joining us, triaging, pediatric triaging and emergency interventions. We've done justice to the aspect of triaging. We've been able to talk about classifying children into those who have emergency signs, who have priority signs, and those who are not none of those classes, which we loosely call the cold cases. But every child that comes to the hospital is important and must be treated with dignity. So let's delve into emergency interventions immediately.
Okay, and by definition, thank you very much. A medical emergency can be defined as an acute change in physiological and psychological status likely to result in death if no intervention is given. Now, but it can also result in disability or delayed recovery. Delayed recovery. So these three things, if you don't intervene immediately, it may result in death, it may result in disability, or it may result in delayed recovery. Okay, so that's an emergency.
Okay.
All right.
All right. So how do we assess them? I can see
a
rectangle, a triangular glass prism here.
Exactly. It has three sides. There's the appearance, You look at the work of breathing and you look at the circulation, like we've said before. What's the appearance of this child? The tone? Is this child just flabby, hypotonic? Okay. You also look at, is this child interacting with you? Is the child interacting with the environment? Is the child even aware of where he or she is? You look at, if this child is crying, can this child be consoled? Even when the mother is carrying the child is still screaming. You know this child is in severe distress. Okay. You also look at this child. How is this child gazing? Is this child just looking at one place and looking straight? Of course, it could be a subtle seizure. Okay. And then the speech and the cry of the child is very important. There are children that cry and is very loud, shrill cry. Oh, you think they are crying. You won't know this child is actually having a seizure. Okay. And then you look at the work of breathing. Is there any abnormal breathing? You've seen children that are breathing very fast, deep and fast. We call Cosmo breathing. And then is there abnormal positioning? Is the child positioning, trying to, maybe the child is having pain in one leg and trying to position himself to help reduce the pain. So these are the things you have to look out for. Are there retractions?
I think other abnormal position like the tripod sign in acute epiglottitis.
Okay.
Some of those signs that are specific for some disease entities.
Knee to chest
position. Children who have death spells in tetralogy of Fallot.
Exactly. Squatting.
Yes, squatting. It's all right.
All right. So you also look at the circulation. Is the child pale? Is there mottled appearance? Like we see in some of the patients presenting with CKD, cyanosis, and is the child bleeding actively? So these are the things you need to find out. Quick assessment. Very few seconds, you've already done these three things, and then you move on.
So it's important to know what to do when we face with the children. But we have some emergencies we'll quickly run through so that after being able to stratify based on emergency care, urgent care, or priority and other, so we actually know what to do. So we have some of them here: respiratory emergencies, foreign body aspiration, heart failure, children who present with status epilepticus, then severe dehydration or hypovolemic shock, which we've talked a little about, poisoning and anaphylaxis. Okay, fine. So we would start with the respiratory emergencies.
Okay, what's the goal of management in respiratory emergencies? What do you want to achieve? First of all, you have to ensure a patent airway. It's very important. Like I said before, if you have secretions, you have to suction the patient appropriately. If you have any obstruction that will prevent air from getting into the child, you can use an oropharyngeal airway. You can also use a nasopharyngeal airway to make sure that air gets into this child. And the second goal is to provide necessary support for adequate oxygenation of the blood and then removal of CO2. So in this, you can give the child oxygen, especially when the SpO2 is less than, of course, you don't wait for it to get to less than 93%. If it's less than 95, you can actually start 100% oxygen. Okay. And then,
also to add about the airways, because we talked about laryngeal mass airway, pharyngeal airway, also intubation, because every doctor who treats children should know how to intubate. It's quite easy. A doctor who can set an IV line. We remember our first experience, maybe during house job, setting an IV line. Every doctor who can set an IV line should be able to intubate. It's quite simple. With the laryngoscope blade on your left hand, the child supine, the neck extended. It's quite easy because when you look, first of all, you are looking at, I just simply say, a dark space. That is esophagus. If you enter that space, you intubated the esophagus. And when you ventilate, the child's abdomen will rise. It will just get filled with air. So, but because the larynx is anterosuperior, the laryngoscope is moved superiorly and back towards you. And you now see the slit-like opening of the larynx, then you can enter. So the child can be intubated to maintain airway. So it's quite necessary that we are able to do that. and provide necessary support for ventilation. If need be, we use our mechanical ventilator, which we have a dedicated ventilator for use in Limit Children's Hospital. Can take from babies of as low as whatever, 100 grams, whatever, till 10 kg. You understand? We could do that. Okay, fine. So we're talking about hypoxemia, which is a threatening life condition.
So therefore, initial therapy for respiratory failure should be aimed at ensuring adequate oxygenation.
Yes.
So that's the aim. Let this child be oxygenated. Okay.
Okay, somebody said if I could quickly recap what I said about intubation. So the child, okay, because of this, in our series of webinars, we will talk about neonatal ventilation. So we talk about the different airways. But for the purpose of the question that was raised, the baby is lying supine, the neck is tilted upward, so we just want to extend as much as possible. Of course, the person who is going to intubate knows that it's a sterile procedure, glove, gown, mask up, and all that. So you want our eye level to be at the level of the airway of the baby. So we'll have to squat, respect the baby, kneel down for the baby, squat if necessary. Yes. So with the laryngoscope put on our left hand, we enter the buccal cavity and go down as much as possible. Of course, we know the laryngoscope blades have various sizes. Size 00 for the very preterm babies, 00, then O, then 1, like that. So get the appropriate size laryngoscope. So you just go down with the neck extended as much as possible with some little cricoid pressure by the assistant. Okay, so it's quite easy because you would see the esophagus immediately. A wide space, which is dark, which does not change with phase of respiration. So we do not want to enter that space. That one is passing an NG tube. So, but because the larynx is anterior-superior to the esophagus, the blade of the larynx, which should have very good lighting system, is tilted upwards a little bit and backwards towards you. So you go anterior, superior, and anteriorly. Then we're able to see a slit-like opening that opens and closes with phases of respiration. We may need to suction intermittently, but this has to be done within seconds because we don't want to get the child should have been pre-oxygenated, so we do it as fast as possible. Seeing that slit-like opening, we enter. At the point of entering, gentle cricoid pressure makes the airway more straight for us to enter, and then the child can be intubated. So it's necessary to be able to get the airway patent.
Thank you very much, Dr. Peter.
Yeah, thanks. Oops. Okay, so, all right. So just to recap a little, we've talked about the goals of airway management. We've said ensure the airway is patent, provide necessary support for oxygenation. What else do we do?
Okay, in ensuring a patent airway, we've already talked about if there's any foreign body, you make sure you remove it. Okay, suction out any secretions. Consider use of pharyngeal airways. Intubation may be considered, and then emergency tracheostomy may also be very important.
Yeah, so this is where interventions become very necessary.
Exactly.
At the point of tracheostomy, if unsure, call for ENT. We have our ENT unit, but it's also important because that one becomes really invasive. Okay, fine. Okay. So for oxygenation of the blood.
Okay, you can give supplemental oxygen. Okay. You can give inhaled gases, helium oxygen mixture. Yeah. You can give positive pressure respiratory support.
So
like we see our continuous positive airway pressure.
So concerning that, I know that in town there is so much improvised CPAP, which seem to be helping better than straightforward oxygen. But please, there are standard CPAP machines. We have like 3 of them functional. So where you just want to set the dose of oxygen FIO to the fraction of inspired oxygen. You want to check the PEEP, and all that, very necessary for CPAP monitoring. Whereas they improvise to help, but we aim at what is standard, which is, and in fact, the mechanical ventilation, which is the next one, also has a mode for continuous positive airway pressure. You understand? So, and then mechanical ventilation.
Now, other measures might include it to be nebulization if it's necessary, correction of hypoglycemia if the patient is hypoglycemic, and use of IV fluid if the patient needs that, and every other supportive nursing care that the patient might need. They are also very important.
It's okay. Thanks very much for that. So we make progress. So foreign body aspiration. Wow.
Okay, this is very important, especially in children that are less than 4 years, because it has been seen very commonly in this kind of children. Of course, you know, children at that age are very
adventurous.
Very adventurous. Anything they get, it either enters into any opening. Nose, mouth, ear, and then common objects like we know include nuts, especially groundnuts, and then some seeds. Bottle covers, all these Coke bottles. Of course, that one will sit on the pharynx and obstruct the airway completely. Okay. And then you look at some other small objects that they can actually, coins, like when we were younger, when coin is available. At least I remembered swallowing coin. I had to wait for some time to defecate it. So thank God it didn't enter my airway.
No, that one went to digestive tract. You're talking of aspiration.
It didn't enter my airway.
Also, fishbone. Fishbone is a very important culprit here. It can just sit on the larynx and cause so much trouble. So we've seen those kind of patients in our center here that presented to emergency room with a lot of respiratory distress, because the upper airway is obstructed. Referred to us, and the child had same repeated nebulizations. Could this be an asthmatic attack? Repeated nebulizations until the history was found. Anyway, I know I'm going to talk more about it, but however, about the history, usually it's of sudden onset. The respiratory distress in foreign body aspiration is usually of sudden onset. So the timeline for, let's say, respiratory distress in asthma, it will be a little different from foreign body aspiration. So you could remember that, as at the point the child just started eating. So the child was apparently well until when the child just started eating. You understand? And all that. Or for nuts, the child was given granite by the aunt who just came back from village, and the child started eating. This is not village people anyway, it's granite and it's foreign body aspiration. So if it's an infant, what do you do?
So if it's an infant, the first thing you do is to lay the infant on your arm or on your thigh. Okay, with the head slightly facing downwards.
Okay, so I think there is an image, a diagram. I will go forwards and then come backwards. Fine.
Okay, that's the diagram.
Yes.
And then you use the heel of your palm and then 5 blows on the back. You just the direction the arrow is showing.
Yes.
Okay. And then after doing that, it is expected that the object will come out. But if the object does not come out, you looked at the mouth, the object has not come out, you turn the child, and then with 2 of your fingers, a finger breadth below the breast line, you apply 5 pressures, just the same direction as shown in the picture. 5 times. And after that, you check the mouth of the child to see whether the object is now visible and can be removed. Okay, and then you bring it out. But in a case where it doesn't happen that way, you can repeat for at least 3 times. And then possibly either refer to an ENT or call an ENT as fast as possible to come and do a maneuver.
So just like a note of warning, we would want to discourage the habit of using the finger to poke deep into the oropharynx in an attempt to look for you just further push it down. So that must be noted. Okay, fine. So back to
Okay. Like I said, lay the infant on your arm or thigh in a head down position. Give 5 blows
yeah.
to the infant's back with heel of the hand. If obstruction persists, you turn the child and then use your fingers. If obstruction persists, you can check the infant's mouth. If it is now removable, you remove it. But if it's not, you don't have to force your hand like he has just said into the mouth because in doing that, you may push it further in. And then if necessary, you can repeat the sequence with back slaps again. But if this child is more than 1 year, the maneuver is slightly modified.
Yeah. Okay. So for a child older than 1 year,
For a child older than 1 year, what you do is you go to the back of the child, and one of your hands will form a fist just below the sternum, and then the other hand on top of it, like you can see in the picture. And then you apply a deep pressure
around the epigastric
region. Yes, to see whether the object can be pushed up. You do it for 5 times. And if there is no success, you can still repeat. All right.
Okay, well, let's just go to the slide that talked about that. So this is what we just talked about. So if necessary, repeat this sequence with back slaps again. We repeat on and on. Okay, fine. So we now talk about heart failure. Well, for heart failure as one of the emergency presentations, we know that the heart fails when it's unable to deliver the adequate cardiac output to meet the metabolic demands. We'll be brief about heart failure because we've had a webinar session fully on heart failure. But generally, we want to make sure that one general concept is this child may require oxygen supplementation in propped up position. That is supportive care. We want the child to be warm and handled gently. Cautious fluid administration because the heart is failing to deliver enough circulation. So that is cautious fluid administration. We want optimal caloric intake. Now we want to look at the various causes of heart failure in pediatrics. Would it be anemia, anemic heart failure? Would it be bronchopneumonia, that's chest infection, failure, electrolyte imbalance? A lot of children who have malaria who have had borderline part cell volumes. The lysis from the malaria will cause anemia and then tilt into heart failure. And the presenter also just talked about pulmonary edema as a complication in severe malaria, which can also cause heart failure. So for those who have, for such children, we want to support them with preload reducers as much as possible, furosemide, spironolactone, when we go so long on furosemide. And then for those who have pump failure from cardiomyopathies, like dilated cardiomyopathy in particular, we want to give positive inotropic agents. All right. So we have a situation where a child is presenting with status epilepticus. So what's all about status epilepticus?
Okay, status epilepticus is continuous seizure activity or recurrent seizure activity without regaining of consciousness, lasting for more than 5 minutes. Initially it was 30 minutes, but it has been reduced to 5 minutes because it has been noticed that any seizure lasting for more than 5 minutes will cause some complications already. So, and then we say as soon as it's 5 minutes, we classify it as status because you need to start intervention immediately.
Okay, sorry, please. We want to pause the presentation at this point. We have 2 participants raising their hands. First of all, before we get to them, I would suggest if it's a question, you put it on the Q&A section because I want to address those questions right away. And then if you have a chat, you put on chat box. Okay, fine. So let's address some questions. Thanks for the presentation. How do we determine the amount of oxygen that a child with respiratory distress needs? Now, we say oxygen is a drug, and the dose of oxygen is a fraction of inspired oxygen. Now, atmospheric oxygen has about 21% oxygen, whereas we know that our cylinders could live up to 100%. But we want to start as low as possible, as atmospheric as possible. Now, which device will give the oxygen as a drug is the mechanical ventilator and the actual CPAP machines. So these have settings on the screen of our GE product, which is one of the wonders of medicine. We have the settings. So you set, normally it is said you start with the lowest possible and increase gradually as is necessary. So we start with an FiO2 of 21. You could start and then increase gradually. We wouldn't want to be careful with giving hyperbaric oxygen. We know that some children, if we are talking of neonates in this case, who have suffered retrolental fibroplasia. I recently got to know that Steve Wonder, those who are old enough, those who are old enough know Steve Wonder, who is a musician, who was delivered preterm and was given oxygen profusely and suffered retrolental fibroplasia. So we want to start with an FiO2 setting on the ventilator as low as 21, and then monitor response on the basis of oxygen saturation and other parameters, because the ventilator setting has other parameters to do, like the tidal volume, which you have the pediatric range, the positive end expiratory pressure, the positive peak inspiratory pressure. All these parameters add up to the mean airway pressure, which will determine what the child will get. So determining the dose of oxygen depends on the clinical condition of the child. Yes. Okay, fine. So, but there's another question. Okay, we have two other questions. Okay. What does mottling indicate?
Okay.
Yeah. So I think this was one of the signs in triaging.
I mentioned, yes. Yeah. Mottling actually indicates a vasoconstriction. Blood is not getting to the skin the way it should get.
Yeah.
So that is what causes mottling. You are looking at the child is looking as if the child is pale.
Yeah.
But when you take when you check the PCV, you actually find out that the child is not pale. Okay. For instance, the way it has been described is if you see a dead child, just that appearance is what is called mottling appearance. Okay, so that is what it is.
Okay, fine. So we therefore know that in mottling, circulation to the cutaneous circulation is compromised. Yes, it's okay, fine. So back to status epilepticus.
Okay, a seizure which shows no clinical signs of arresting after a duration, encompassing the great majority of seizures. Like, for instance, people present with seizures and they say it lasts for 1 minute, 2 minutes, and then you have a child presenting and then the mother is saying this seizure lasted for 10 to 15 minutes.
Yeah.
Yes, you can actually classify that as a status. Depending on the seizure type. There are some types of seizures that just last very, like akinetic seizures, the child just falls down, drops. Okay, and then when you have that, and then some absence that the child stares for some time, and then continues blanks, and then continues with the normal activity. So when they last more than they should, any seizure type that lasts more than typical, then you can say this child has a status epilepticus.
Okay, so by just like on a lighter note, is like some of us as medical students had absence during oral exams. Thank God it didn't get to status. All right, so fine. So we have an algorithm for the management of status epilepticus. This slide is very, very important, and every doctor that sees children should have knowledge of this slide. So can you enlighten us more on this slide? Okay,
the targets when a child comes in with a status epilepticus, especially if the child is convulsing presently, is to make sure that the seizure is controlled within 30 minutes as much as possible. Now, there are classes of drugs that are involved. Anyway, the first thing you do is to manage the airway. Like we have said before, is this child, are there secretions? You have to suction the child. You check the SpO2 to know whether this child needs oxygen. Of course, you give oxygen. and then you look at the circulation. Is this child in shock? All those things should be managed. Check for random blood sugar. And then all that are part of the symptomatic management. Then to control the seizure, the first group of drugs we look at is benzodiazepines. The diazepam is very, very, very handy. It can be given both rectally. It can also be given intravenously.
Yeah.
It can also be given intraosseous. Very, very important.
Yes.
Because in most children, when they present like that, it's always difficult to get an IV access. So you can actually use the intraosseous route.
Okay, so a word on intraosseous routes. Every doctor managing emergency, except you have signed that you are going to focus on only OPD, and that the OPD will be screened by another doctor before referring to you, else you will need to make this. And every doctor should know how to get intraosseous access. So I'll just explain again. So with a child lying supine on a rigid surface, so the couch we have in consulting room or emergency room is what is ideal, not the beds we have on the ward, because that one is not rigid. So the baby or the child on a rigid surface, we locate the tibial tuberosity, and then anteromedially we have a soft surface of that tibia. So you want to go a finger breadth below the tibial tuberosity, which is like 2 cm below, and then you try to go perpendicular downwards. So you go with confidence. With gentle pressure until you feel the give. You can now stop at that point. You are in the intraosseous space.
Okay.
Yeah, so I can see on this algorithm before you continue that there are interventions that are based on timelines. Within more than 5 minutes, 5 to 30 minutes, refractory, if it continues more than 10 minutes, and then more than 30 minutes. These timelines are important because if we get a child presenting with seizure that we can determine it's up to 20 minutes. We know we are facing the management plan between 5 and 30 minutes. But that's just an overview, so you can proceed.
Okay. We've talked about diazepam.
Yeah.
Diazepam can be repeated. If the seizure is not abating, you can repeat the diazepam for the second dose. And after that, if the seizure continues, though we don't pray it does, but we've seen such cases, very, very recalcitrant and stubborn seizures. They continue. Even after you've given the second dose of diazepam, you move to the second line drugs. You start with phenytoin. You give a loading dose of 20 milligram per kg, and then after that you maintain with 5 milligram per kg per day in 2 divided doses 12 hourly. So
as infusion.
Yes, we put it in an infusion.
Okay, so what the presenter has said so far, it's important we understand the sequence of drugs. So we start with the benzodiazepines, now we go to the phenytoin. Okay, fine, continue.
Okay. Now, if the seizure is not abating, we go to the next group of drugs. Okay, and that includes you can give any one of these midazolam, IV midazolam. You can also give IV phenobarbital. You can give IV levetiracetam, depending on which one is available to you and some other considerations of the patient that is in front of you. You can also give IV valproate. The doses are shown on the screen. So it's very important we know this. Then,
okay, sorry for cutting again.
Okay,
again, we have 2 participants raising their hands. Would you mind please writing the questions, concerns into the chat box, the Q&A, so we'll address it as we progress. Thank you. Okay, continue.
Okay, when you have given these 2 groups of drugs and then the seizure continues, you can classify that seizure that status epilepticus as refractory. Okay, some people have also loosely classified seizures that have lasted for more than 1 hour as being refractory. So in this case, what do you do? Of course, refractory seizures are managed in the ICU. You have to move the child to the ICU. This child should be intubated, and then there should be an ECG monitoring, okay, which is very, very important because some of the drugs you are going to give might affect the
cardiovascular.
yes, the heartbeat and all that. So, and this is when you now commence on some IV infusions. You want to induce coma. For instance, you can use a phenytoin drip that will last for a long period of time, or you can use diazepam drip. You remember the patient we managed that we used diazepam drip, and then we induced coma for a period of up to 48 hours.
Yes.
Okay. And that's actually helped us in managing that patient. In fact, they came today for a
yeah, if I was taking pictures with them. It's
the child has actually done very well.
Yeah. Okay, so let's see. Somebody has a question here. Is the use of paraldehyde in order? Okay, fine. So don't worry. The next few slides, our next slide will address that. So the question on paraldehyde is important, but we'll address that. Okay, fine. So on the basis of this algorithm, we go benzodiazepines, phenytoin, then we should get results. Consult a pediatrician if you have reached that stage. Then, if we're having refractory seizures, we could do midazolam, phenobarbital, levetiracetam, all intravenous. Okay, fine. So if we get refractory, at this point, we discuss with a pediatric neurologist and intensivist about inducing coma. So let's test ourselves to know what progress we've done so far. Now, there is a question in front of us. So, the Tony we have here is a 3-year-old Tony. So I'm sure there's no doctor who may be Tony who will be 3 years old. So pardon us. So Tony is a 3-year-old boy who presents to emergency room with history of seizure for 15 minutes. 15 minutes. What sequence of 3 drugs will you administer? Now, this question is already in the polls. So I would be glad to have the participants attempt answering these questions. We'll analyze the polls as we make progress. Okay, so thank you. So first one, option A, diazepam, phenytoin, phenobarbital, diazepam, phenobarbital, phenytoin, midazolam, phenobarbital, levetiracetam, paraldehyde, diazepam, and phenobarbital. So let's know your answer. We'll analyze the polls and know. Someone has already given an answer. Another person has given. So let's wait and see. I think that's the questions. Those are those questions we have so far. Okay, fine. So we'll make progress and come back to the question. Okay, so we have a child now who has severe dehydration, or the child has shock. We've talked about correction of deficits, maintenance, ongoing loss. So can you expatiate on that, please?
Okay. Of course, we know there are 3 levels of management of a child who presents with dehydration. The first thing you talk about is management. You have to correct the deficits, you maintain, and then you also correct ongoing loss. So for correction for a child with severe dehydration, you want to give 100 ml per kg of either a lactated Ringer's solution or normal saline. And then there are some things you do for this patient in order to monitor the progress of the patient. Like you mentioned before, you have to pass a urinary catheter to check for urine output.
Yeah.
Okay. Now, somebody may ask, what are the signs of this severe dehydration?
Yeah.
Okay. The signs will depend on whether the child is malnourished or the child is not malnourished too.
Yeah.
For a malnourished child, you may not use the common things that we know, like very sunken eyeball, reduced skin tone, because this child, child does not have subcutaneous
issues. It's all fixed as if it's fixed.
So you can use those ones, to determine the level of dehydration in such patients. Rather, you will use things like the pulse.
Yeah.
The pulse may be fast and steady, or just increased more than it should be for the age of the child. Yeah. You also use urine output. You can ask the mother when the child passed urine last, and then the mother can tell you. Those can help you to know whether this child. And then you also, if a child presents to you with dehydration and is lethargic, is also one of the things that can tell you that this dehydration is actually severe. So you correct 100 ml per kg using Ringer's lactate or normal saline in 2 stages over 4 to 6 hours. Okay. And the first stage you want to, we usually call it loosely, giving anti-shock. So you give 20 ml per kg over 30 minutes if the child is greater than 1 year. Or over 1 hour. If the child is less than 1 year, a child that is less than 1 year, the heart might still not have developed well, flappy and all that. So you don't want to give so much fluid. Then after that, you reassess. And then your reassessment will include the pulse, the level of consciousness, and urine output as this child started making urine and all that. If the above parameters are still on the negative side, you can repeat. Okay. And after that, you move to the second stage.
Okay, sorry, before the second stage, it's important we know because reassessment, severe dehydration, shock, 3 basic systems are severely affected. Cardiovascular system, the central nervous system, and the urogenital. Under the cardiovascular system, pulse analysis, you're checking the pulse rate, the pulse volume. Pulse rate, pulse volume. We're also checking capillary refill time. We're checking blood pressure. So all these go haywire in children with shock. Then consciousness, we would want to be exact to tell what the Glasgow Coma score is. Although you know that the child that is lethargic is already lethargic.
Exactly.
Then passage of urethral catheter should be something we do very frequently under aseptic conditions in pediatrics to be able to estimate a volume of fluid loss. At this point, can we just see the Q&A and know what we have here? Okay, so we have a lot of answers already. Wow. So we have differences. So we would analyze them. Okay, so a lot of people. Okay, fine. We'll come back to that. Good attempts. All right, fine. So second stage.
Okay, now the second stage will entail the completion of the correction of deficits. So it will depend on the quantity of fluid you used to correct the shock. If you, of course, the remaining ones, you now use it to correct the deficit. You give the remaining fluid over the remaining time to make it 6 hours in children less than 1 year, or 4 hours in those greater than 1 year. Okay.
It's okay, fine. The timeline vis-a-vis the age of the child matters a lot.
Exactly.
Yes, it's important to know that for younger children, we take longer duration. For younger children, we take a longer duration. You do not want to drown the child in his own kind of fluid. Yes. Okay.
Okay.
All right. Wow. This is
we have a beautiful picture.
Not beautiful at all. It's okay.
Okay. This, of course, the signs of dehydration are there looking at us. My left, you can see the child with sunken eyeball, lethargic, and of course the skin toggle is still there. Even after the doctor had raised has removed his hand or her hand, is still present. This child is actually in severe dehydration. Okay, and then the second picture is just to buttress our points. You can see the very sunken eyeball. And then even the patched lips. Okay. There. All right.
Okay. So just to be sure. Okay. So correction of deficits, we've talked about it, having to do a lot with the age of the child. So maintenance and ongoing loss.
Okay, if the child can tolerate orally, we always say you use ORS. And correct for the maintenance. If the child can now tolerate orally, but if the child cannot, you also continue in the intravenous way. Now the fluid will be detected by then the serum electrolyte urine creatinine should be out. Of course, in 1 to 2 hours here, our serum electrolyte urine creatinine results is out. So we look at it. And that will determine the type of fluid we use for the maintenance. Okay. And then we do 100 mils per kg for the first 10 kg, then 50 mils per kg for the next additional 10 kg, and then 20 mils for the remaining 10 kg is given over the remaining 24 hours. Exactly. And then ongoing loss, of course, if you are treating a child, the child may still be passing watery stools while you are correcting. So you give the ongoing loss. It can actually be given as ORS orally. The child can tolerate orally. You still add, or you add it to the IV fluid at 10 mils per kg per loose stool or vomitus, but you do not exceed 100 mils. Okay.
Yeah,
So
it's okay. So what? But we commonly find mothers who just do not. This baby will not take ORS. This baby will not take ORS, but the baby needs ORS. We give them the option of passing in nasogastric too.
nasogastric
Give the
tube,
option
actually.
of passing in nasogastric too. It's okay, fine.
So I usually say that every mother should have an ORS in their house.
Yeah.
It's very, very important. Okay.
It's okay, fine. So we've touched airways, the emergency conditions, interventions for airway abnormalities, foreign body in the airway. We've talked about shock. We've talked about status epilepticus. We just finished talking about severe dehydration and shock. But before we proceed, I think we should revisit the polls to just make an analysis.
Okay.
Let's give an answer, because we've seen that most people got the answer, and that's good that you've been following. Okay, let's look at the question now. Tony, a 3-year-old boy, presents to emergency room with history of seizure for 15 minutes. What sequence of 3 drugs will you administer? We go for the first option. So those who chose I, if I am right, saying those who chose A say I, then I'll say the eyes have it. So those who chose A, they have it. So if you look at the algorithm we have, it's there: diazepam, phenytoin, then we now consider phenobarbital in that sequence. Why this question is important is because in most centers, maybe because of non-availability of phenytoin, people jump to phenobarbital before phenytoin, and that's one point we want to correct in this presentation. So it's phenytoin before phenobarbital. Okay, fine. So so where is the place of paraldehyde now? Paraldehyde is shock acting. It's intramuscular. You would want to give it, I would think, just before you want to induce coma, because you would have done the common things that should be done. But in the sequence of drugs, diazepam, phenytoin, phenobarbital before paraldehyde. But I know why people jump to paraldehyde is because of the ease of remembering the dosage and the fact that it can be given intramuscularly. Yes. Okay, fine. So we look at poisoning. Yeah.
Okay. Poisoning is very common in pediatric practice, especially in the emergency room. Majority of children who present in our emergency room are actually poisoned in their home. Domestic poisoning.
Yeah.
Okay. And most involve a single substance. And then the mode of ingestion is usually oral. The mode of poisoning is usually orally. Like about 50%, more than 90% of cases that present is usually orally. And then poisoning can also occur through the dermal route. It can also be inhalational. It can also be through the eye. Okay. And then, of course, poisoning can include both drugs and non-drug substances. Drugs include iron. Okay. Of course, you know, syrup, iron syrups, quite a number of them are very sweet. Children will always want to. I remember my friend telling me that his brother had to climb 3 stools to bring down the drug on a shelf and then finished everything and slept off there.
Tastes like chocolate.
Okay.
It's okay.
And then you have hydrocarbons, the organophosphates, used in the treatment of insects that is found in most insecticides. Okay. Now, what are the principles of management? Okay. First of all, is supportive care. Okay. When a child presents, a child is poisoned, the first thing you do is to look at the ABCD. Look at the airway. Are there secretions, suction? Is the child breathing well? The child may require oxygen. You also look at this child might be hypoglycemic, so you do a quick random blood sugar and correct if it's less than. Of course, a lot of people say 45 milligram per DL, but quite a number have also proposed 54 milligram per DL, which is 3 millimole per liter. So you don't wait for it to go down.
The idea is to catch it as early as possible.
Exactly. So these are supportive cares that you can do. You look at the clothes. Are there some of the poisons on the clothes? You have to remove the clothes in order to prevent the child from
the dermal
roots. Exactly. And then the next thing are the antidotes. Antidotes are some other chemical substances that you give that will react, or more like react with the poison and prevent the poison from actually damaging the body tissues the way it should. Like when you talk about iron, of course, we know deferoxamine that chelates iron is a good antidote. Another one is the contamination. You want to prevent the absorption of those poisons as much as possible. For instance, a child may take some substances that are absorbable using activated charcoal.
Yes,
absolutely. So you can actually give that. You can actually do a whole bowel irrigation to wash out those substances. These are modes of the contamination. And then enhanced elimination, like alkalinization of the urine. Okay. In enhanced elimination, those substances have actually been absorbed and they've entered into the body. But you want to find a way to remove as many of them as possible. So you can do alkalinize the urine. You can also do dialysis. Okay. So these are modes of enhanced elimination.
Okay, fine. So we get straight into some forms of poisoning.
Okay.
First of all, organophosphate poisoning. Let's see.
Okay, we have a scenario here. A 2-year-old boy was rushed to emergency room in coma and had convulsed twice. He was said to have drank from a clear substance in an Eva bottle container in her grandmother's room. And grandma says she usually sprays it in her room to kill insects. On examination, he was in marked respiratory distress with excessive secretions from the mouth and then conscripted pupils bilaterally, with a temperature of 7.4 degrees centigrade and pulse rate of 200 beats per minute. So
wow, this is tachycardia.
This is a typical picture. Of course, when I mentioned the clear substance in an Eva bottle, it's typical. Some people store insecticides in bottles that are used to store water. It's highly discouraged. Because children, especially when they come back from school and they are thirsty, anything they see around that is clear is water. Okay.
So some people store kerosene in it.
Exactly.
So kerosene poisoning is also there, and then insecticides being stored.
Exactly. Okay. So what will you do for this child? That's the question. The child is before you in an emergency room. Okay.
It's okay, fine.
Okay, let's say some things about organophosphate and carbamet poisoning. Of course, we know there are all these pesticides, insecticides, they contain organophosphates. And so it's a common thing in your house. You see people who keep some of them close to where children can immediately pick them and then ingest them. So what do they do? Okay, we know acetylcholinesterase is supposed to degrade acetylcholine at both muscarinic and nicotinic receptors.
And the neuromuscular junction.
Exactly, at the neuromuscular junction. So when they take these pesticides and insecticides that contain organophosphate and carbamet, what they do is they prevent this acetylcholinesterase from doing their work. And then acetylcholine will have a field day. Will continue its effects on these neuromuscular junctions. Okay. Now, diagnosis is simply based on history. Like I said, a child drank. Then, when the child presents, you can perceive the odor. Okay, and from there you can like say, okay, this child actually took something that is toxic. And then the physical examination findings will also help. Now, cholinergic excess at the muscarinic receptor, there's the acronym dumbbells.
Okay, sorry. Now, the presentation for those just joining us, we are on organophosphate poisoning. Now, organophosphates act at the neuromuscular junction, and the clinical manifestations could either be due to cholinergic signs or nicotinic signs. So, considering the cholinergic excess at the muscle, the neuromuscular junctions could be have muscarinic receptors. If you look at muscarinic receptors, nicotinic receptors, they have different effects based on So for muscarinic receptors,
okay, the acronym is dumbbells, and D is for diarrhea, and or stroke defecation, U urination, Then meiosis, that's constriction of the pupils, like in the patient, the picture that was painted. You also have bronchuria, bradycardia. Then E is for emesis, L for lacrimation, and salivation. Now, the way I say it is this: this cholinergic effect will anything that has to do with bringing out something from the body.
Yeah.
Okay. Child is passing watery stools from the anus, vomiting from the mouth, like tearing from the eyes, salivation, and all that. So somehow. Now you now have the nicotinic signs, which includes muscle weakness. Nicotinic is just mostly about the muscles, the CNS, and then the heart. You have muscle weakness, fasciculation, tremors, hypoventilation because of diaphragmatic weakness. Talk about hypertension, tachycardia, and dysrhythmias. So that means a patient who presents with organophosphate poisoning can actually either come down with tachycardia or come down with bradycardia.
Yeah. So so looking at pulse, you can tell if it's from nicotinic or if it's muscarinic.
Exactly.
So if it's bradycardia, simple muscarinic effects, tachycardia, nicotinic effects.
Then the severe manifestations will include coma, seizures, shock, arrhythmias, and respiratory failure. Okay. So how do you manage?
Okay, fine. So this management will address the question that was raised earlier of this 2-year-old boy. So fine. So we'll look at the management and then we're going to take care of it.
So the first thing you do, like I said before, is to symptomatic management. You want to do your resuscitation, ABC, and then remove contaminated clothing and wash any exposed area with soap and water to prevent any dermal injury. Then for organophosphates, they can actually be absorbed by activated charcoal. So if the child comes within maybe the first 15 minutes, of course, the absorption may not have completely taken place. So activated charcoal can help. You can also do a gastric lavage. So there are forms of decontamination that can be done. Then you can also, you now give, like we tried to explain, there are muscarinic receptors and you have the nicotinic receptors. The muscarinic receptors will give you a cholinergic effect, while the nicotinic receptors will give you a nicotinic effect. So we'll have two antidotes to handle both effects. Okay. The atropine will handle the nicotinic effect. So you give this child IV atropine 0.05 milligram per kg every 15 minutes until the child is fully atropinized. How do you know that? If the child had presented with tachycardia, the pulse rate would have been going down. The skin will be flushed, warmer than it was before, and all those. So you check all those things, and then after that, you must keep this child atropinized for a period of 24 hours. So you give a continuous atropine, you put it in IV drip, and then give it continuously over a period of 24 hours. Okay. Now, for the muscarinic effect, that's cholinergic effect. Sorry. I think I turned it the other way. The atropine is for nicotinic. Yes, for the atropine is for the cholinergic effect. Sorry.
Okay, so let's go back to the effect. So we have signs on nicotinic receptors and signs on the muscarinic receptors. And for muscarinic, which is cholinergic, we talked about excessive secretions from various orifices with bradycardia.
Atropine.
Now, weakness and other things will be the nicotinic. Fine. So let's see. Atropine versus pralidoxime.
Atropine handles the muscarinic effects.
Okay, fine. So back to this slide. So we have the muscarinic effect, excessive secretion. So by the time the child is fully atropinized, secretions should dry. Secretions should dry.
Then the meiosis. You look at the pupils, you find that the pupils they've come back to normal.
Yes.
Okay. So IV pralidoxime is given at 25 to 50 milligram per kg over 30 minutes, and then is repeated until the symptoms the patient presents with results. Now, for these patients, our case patients who presented with seizures, you also give them, you treat these convulsions with diazepam. Okay, and then because atropine causes pulmonary congestion, so in order to prevent that from happening, you can give this child IV furosemide. Okay, so these are the things you do for a child who presents. Now the next one is hydrocarbons. The commonest one is kerosene.
Okay, let's see if we have questions that have not been answered. Okay, good afternoon, sir. Please, in the absence of activated charcoal, what next will you do? Anyway, for
gastric lavage.
Gastric lavage, you could do gastric lavage. Okay.
So for hydrocarbons, of course, we know the commonest one, that's kerosene, though it has reduced markedly these days because of the use of gas.
Yes, kerosene is more expensive than gas now. Okay.
It has reduced markedly. Okay, but of course, the treatment, this thing is still the same thing, symptomatic treatment. Okay, and then emesis and lavage are contraindicated in hydrocarbon poisoning. You don't.
In fact, it should have been red.
It's very important. You don't induce emesis. You don't give a lavage. The reason is because one of the commonest thing that kills them is aspiration, and then aspiration pneumonitis. So you don't induce emesis. Activated charcoal is not useful because it does not absorb hydrocarbon. Some other things that activated charcoal does not absorb include caustics.
Yes.
It doesn't absorb alcohol. It doesn't absorb hydrocarbons generally. Iron and then lithium. There's this acronym KHIL, K2C and H, 2H. So that you don't bother yourself giving the patient activated charcoal when they present with this kind of poisoning. And then you give a supportive respiratory treatment. It's very, very important, especially if the patient had vomited and then there is a possible pneumonitis. Then neither corticosteroids nor prophylactic antibiotics have shown any clear benefit.
So this steroid controversy continues, but we stand with no need for steroids. Okay.
All right.
Thanks. So we discourage people from putting finger deep into the throats of these people. They say, bring vomiting, take a lot of palm oil and vomit. We want to discourage that. So caustics.
Caustics include both acids and alkali, as well as a few common oxidizing agents. Okay, they are very, very, very toxic. They are very injurious because the injury will start from the skin, the mouth, erosion of the mouth, down to the abdomen. So it's very, very important that anybody who has such things should, as much as possible, rush to the nearest hospital for interventions. Now, strong acids and alkalis can produce severe injury, even in small volume. So you don't say, the child, he just took a little. No, there's nothing like that. Even that little can be very injurious, especially if it's a strong acid or a strong alkali. Now, the severity of the corrosive injury depends on the pH, and concentration of the product, as well as the length of contact time with the product. Very important. All right. Now, what do we do? The first thing you do is, as much as possible, remove the product from the skin and the eye by flushing with water. If it touched the mouth, make sure you flush as much as possible. The person can rinse the mouth and then pour it out as much as possible. Then give supportive and symptomatic care, like we've been saying, for every poisoning. That's very important. Emesis and lavage are contraindicated too. Like I said before, activated charcoal does not absorb caustics, so it's a waste of time giving it. Okay. Then intubation is very, very important in this case. You must intubate the child. It may be very necessary.
For respiratory support.
For respiratory support.
It's okay, fine. That's to clarify, treatment of hydrocarbon poisoning is supportive only. Nothing else is given.
Nothing.
Okay, fine.
You just monitor the patient symptomatically. If the patient develops any symptoms, you manage.
Yes.
You don't give any other things.
It's okay. All right.
Okay, iron. Of course, the problem with iron is the GI gastrointestinal corrosion. It's very corrosive to the GI mucosa. It can lead to hematemesis, melena, ulcerations, infection, and potential perforation. So it's actually very, very toxic. And then it can also lead to hypotension and metabolic acidosis. So what do we do? Close clinical monitoring, aggressive supportive and symptomatic care is very important in a patient who has iron poisoning. Then you can do whole bowel irrigation.
Okay.
Whole bowel irrigation. Of course, what is used? They say polyethylene glycol is used. You can pass it through the through an NG tube, or the child can take orally. Of course, through NG tube is better because you have to do it actively. It's not a passive thing.
Yeah.
So you give, depending on the age of the child, you can give up to 30 mils per kg for children who are less than 1 year. But for children, older children, you can give up to 100 mils. So you continue to push it through the GI until it will now, the child will be passing, urinating and defecating at the same time. So you're trying as much as possible to make sure that they are removed from the GIT so that they don't cause much harm. But the antidote for iron is deferoxamine, given 15 milligrams per kg per hour.
Okay. All right. So look at anaphylaxis. We are getting close to the end, but let's see questions, more questions. How about giving milk or soft meals to patients with acid poisoning?
Well, those things, people do them because of lack of what to do.
Yes.
That is the truth, because they really do not have any effect.
Yeah.
Any effect. Even those things can even induce vomiting.
Yeah.
And then you have a bigger problem in your hands. They are not actually important.
Okay, fine. So I think talking about those caustics, one looks at the mechanism from the pathology.
Okay, liquefaction.
Liquefactive necrosis, coagulative necrosis, and the risk of perforation, and then subsequent stricture formation. So it's better they are taken care of appropriately in the hospital. There are other questions. How about the possible dehydrating effects of lactose? No, we talk about lactose.
No, we didn't mention lactose.
We didn't talk about lactose. All right, fine. So anaphylaxis.
It's a severe life-threatening generalized or systemic hypersensitivity reaction. Okay, and they can be caused by insect bites, snake bites. Even some drugs can actually give you anaphylactic reactions. So it's actually a serious emergency because there is airway compromise, breathing compromise, and circulatory compromise. Even the skin and mucous membrane is also affected in anaphylaxis. So it's very important that whenever it happens, the child should be brought to the hospital immediately. Now, of course, we've mentioned the signs. A child who may be taking a drug and suddenly develops severe respiratory distress. Sometimes you see they develop swelling of the mouth and finds it very difficult to breathe. So that child should be managed as an emergency. Okay?
Okay, fine.
Okay, we've already mentioned this. So what do you do as the management? You must secure the airway.
Yes.
You must secure the airway. And that means that child might even need intubation.
Yes.
As much as possible. And then you must give 100, if possible. If you can get up to 100% oxygen, you have to do that. The reason is because the quantity that may eventually get in may not be up to that. So you try as much as possible to give that. Then you look at the circulation. If the child is in shock, you manage the shock appropriately.
Yeah, anaphylactic shock.
Then you look at the drugs. The drugs are very, very important.
Okay, so
adrenaline.
So we are coming to the end of the presentation.
What are the emergency drugs?
Yes.
Adrenaline is very important. It can be given intravenously. It can also be given intramuscularly. But you gradually titrate it, okay, over a period of time. For the concentration and the doses are slightly different. in younger children and older children. For younger children, you give 1 in 10,000, but for older children, you can give 1 in 1,000. But the dose is still the same, 0.01 okay, ml per kg.
That's for older children.
For older
0.1 ml per kg.
For younger children, yes. If there is hypotension persists despite what you have given, you can obtain an echocardiogram and consider infusing noradrenaline as well as the adrenaline together. That will help the child. But if the child is on beta blocker, the effect of the adrenaline may be blocked too. So you move to glucagon. You can give at 20 to 30 microgram per kg. And antihistamines are also very effective, especially when there are cutaneous symptoms. You can give antihistamine. Promethazine. You can also give, of course, promethazine is the one that is readily given intravenously. So you can give that. You can also give hydrocortisone as a matter of emergency. Then crystalloids, especially if the child is in shock, you correct with 20 mils per kg and then give over a period of time depending on the age of the child.
Okay, so let's see some questions. I missed the last poisoning where activated charcoal is not beneficial.
Okay. I mentioned caustics, cyanide, you have alcohols, you have hydrocarbon, iron, and lithium.
Okay, fine. Which one is better between ET2 and tracheostomy in securing the airway? Well, it depends on what we want to get. Endotracheal tube is always good, but if there is a mechanical obstruction somewhere, okay, maybe if there is a cervical injury that prevents you from being able to position the child appropriately to be able to get in, or maybe there's an upper airway disease. Okay, we say diphtheria where you have that membrane. So if there's that membrane covering the oropharynx, you wouldn't want to go and traumatize it. So you could do tracheostomy. So the indications differ depending on the clinical condition of the child. But most easily, insertion of endotracheal tube should easily be what we can all do. For the tracheostomy, our ENT colleagues are always willing to step in. Okay, fine. So we are happy you spent this time with us discussing pediatric triaging and emergency interventions. We want to thank you for your kind attention and also thank our presenter for doing justice to the topic, even though it's quite vast. Yeah, thank you all. So we are open to questions, and although we've answered quite a lot of them, but we are now open. So fine. So we have these questions. You said correction of shock is 20 mils per kg. Thought it was 30 mils per kg. Don't know if 20 mils per kg is later. So it's bolus. You give, the idea is you're looking at 100 mils per kg. So
because they say 20 to 30 mils.
Yeah, so it's 20 to 30 mils per kg, but you know, you have to repeat it as it goes along. It's okay. So we are open to more questions, more comments. So we've been able to address quite a number of them during the presentation. So, but if there are
great, yes.
Yes. It's okay. So your questions will be, we really appreciate questions to understand if we are making all the necessary impacts we need. Okay, there's one here. Okay, well done, the presenters. Great job. Thanks. We are grateful. We are grateful. Thanks, Dr. KJ. It's all right. Yeah. It's okay. So I think we'll end. Okay, thanks. So this is a presentation from the Limi Children's Hospital webinar series for the month of July. You okay, fine. We have more questions. Giving the doctor, this is political. Giving the doctor to population ratio, how do we easily remember all these at the primary care level where most of these will present? Are there easy access to charts or books for references? So every participant of this webinar would will get the slides. So I think one way, in addition to the CME, the certificates, through the emails that were registered, the slides will be sent to the participants. And just reviewing them, I think it will make it stick. Yeah. Thanks for that question. We hope to increase the doctor patient population if we can. Okay, I thought the 20 meals per. Okay, that has been answered. Please, the last CME. Okay, yeah. So don't worry, we'll address all that. Our IT session unit will handle sending of CME certificates. And okay, thank you. For a child with severe anaphylaxis and airway edema, will ET tube not take longer time compared to tracheostomy? So actually, he said that secure airway early. The longer it takes, the more the edema forms.
Exactly.
And then I think at this point it now depends on the skill of the person, because I will go for a small size ET tube and intubate as fast as possible. We could use a smaller size, but a tracheostomy, yes, if you can do it, but ET tube should be less traumatizing, and then the other medications will take care of the anaphylaxis, and I think you are home and dry. Okay, so let's see if we have more questions. Okay, so I think we are done. We are grateful you were able to sustain your attention up to this time. Once again, we are presenters from the Limi Children's Hospital. We are situated at Ademola Adetukumbo Crescent in Wusetu, Abuja. And our aim, what we hope to achieve, is to make sure that all families are happy with the great health care we deliver to children of all ages, starting from preterm neonates to other neonates, to children, to adolescents. We give all that attention, and we have dedicated consultant cover for 24 hours. So you are sure to get first-hand interaction with well-trained staff who have been managing the airway. Sorry, I talked of airway. Somebody is still talking about the intubation. If the mucous membrane is edematous, how possible to intubate? You know, I said the earlier you do it, the better. But if it's coming so late, you would want to go for the tracheostomy.
But the thing is, tracheostomy, you need to be
well trained.
You
need the skill.
Intubation is easier to do than
it's easier than tracheostomy. But that's where you can do both of them. You can now choose. It's okay, fine. So our sessions, our webinar series, these are part of our community development services to improve knowledge of doctors, so we can get better health care in the country, where somebody has already said in the question and answer chat that we have a low doctor to patient population ratio. So when we have that kind of population ratio, we still want to give as much care as we can, either for those who come to us, who will be referred to us, or for those who will meet the primary care doctors on site, so you know what to do to keep them alive and strong before referral. We can see it's coming. Yeah. Okay, fine. So somebody asked about asthma presentation. You will be interested. It will interest you to know that that's one of the next few presentations we would have. that will come up, and the presenters will really thrill you. Okay, thank you all for your kind attention.
Thank you.
We will be, yes. Okay, yeah. All right, so I think there's a link, so you can just click the link to join the WhatsApp group. There is a chat that was just sent now, so you click the link below to join the webinar WhatsApp group. So I think, yeah, so all CMEs, somebody had earlier posted, they will be rectified by our able IT unit. Okay, thanks. So stop. Okay, that's it. So when, yeah, I'll stop the video. Okay, thank you.